Cool. So let's have a look at this one. So this one says it's a 1 hour after undergoing a colon resection for a sigmoid carcinoma. A 57-year-old woman is tachypnic and agitated in the recovery room. She was extubated in the operating room and is breathing 30% oxygen by a nasal cannula. They give it a height. She's overweight. Her pulse is elevated, respiratory elevated, blood pressure is borderline elevated, and her breath sounds are shallow and symmetrical. Heart sounds normal. And the ABG they give you below. So it says, which of the following is the most appropriate next step in management? So I'm giving you guys a minute for this one. Think about it and drop your answer afterwards, all right? Alrighty, so I'm seeing B and I'm also seeing E. Any other answer before we move on? I'm gonna go through it in a sec, giving you guys 10 more seconds. Alrighty, cool. So I'm seeing B and I'm seeing E. So let's dissect the question and have a look at what's going on here, right? So this is a third order question. So you have different layers to the question, and I think this one was a surgery. So it's testing respiratory, your respiratory knowledge, right? So let's go through all of it. Cool. So first of all, it says 1 hour after a colon resection, right? So I'm underlining that. And she did that colon resection because she had sigmoid carcinoma. So this is 1 hour post-op. She just finished surgery, right? And it says, it's a 57-year-old woman. She's tachypnic, so she's breathing fast. Yeah. And she's agitated in the recovery room. She was extubated in the operating room and breathing 30% oxygen, blah, blah, blah. They mentioned she's very overweight. She's very overweight. This woman, big. She's 44. When you look at the BMI, she's 308 pounds. Her respiratory rate is 120. Her pulse rate is 120. Her respiratory rate is 40. And the blood pressure borderline elevated, right? It also mentions that she's breathing in a shallow manner, but the breathing is symmetric. It also mentions the heart sounds are normal. All of these things are cluing us in on some stuff that we're going to discuss. I'm just underlining it. So then it gives us an ABG. So forgot to mention to you guys, but in your exam, they will have a lab sheet. So, you know, the ABG stuff, your, you know, hematology results, all of those things, it's going to be in the exam on a piece of, on a section that you can access on your screen. So it's very good to commit these things to memory so you can move faster in your exam, but always remember that you have a sheet that you can reference for the values, right? All right, good. So the pH is 7.25. Does anyone know the normal pH, normal PCO2, normal PO2? Just type it in the chat.
pH 7.35 to 7.45.
Uh-huh. And PCO2?
Maybe 35 to 45, I think.
Alrighty, cool. All right, so we're gonna leave it there. I don't really business about the PO2 right now. Let's focus on that. All right. So we have a low pH, we have a high PCO2. So all of these things, it's all adding up to tell us that the patient has a what kind of condition? What kind of condition is this? A respiratory what? Acidosis, right? So that's the first layer that we need to cleave as we're going through this question. So finish the first layer. So now we need to figure out why exactly does this person have a high respiratory rate, right? I mean, why do they have a respiratory acidosis, right? Why is the PCO2 so high? So we're gonna get into that. But let me go through the answer options, rule them out, and then explain exactly what's going on. So let's start. So option A, it says administer a fluid bolus, right? That's wrong. I think everybody ruled that out. And why exactly do we know that, you know, that's completely wrong? If you look at the vitals, the pulse is 120, yes. You could probably argue that, okay, yeah, probably they're compensating for some hypovolemia, but that's not the case. The blood pressure is good. So the pulse is high, but the blood pressure is good. So there's no form of hypovolemia there. So there's no reason to give a fluid bolus, right? They're normotensive, as Abigail mentioned. All right, good. So the next thing, we can look at option C. Option C says diuretic therapy. I'm ruling out the easy ones first. Option C says diuretic therapy. That's also wrong. Why is diuretic therapy wrong? Because they never mention anything about any form of edema. So if they're trying to clue you in on something like, okay, yeah, they have pulmonary edema because they're hypervolemic, they'd mention that, okay, the patient has pitting edema on the legs and all of that stuff. So they never mention anything like that. So you can rule out diuretic therapy. Option D, fiber optic bronchoscopy. You can rule that out as well. What's a fiber optic bronchoscopy? So this is a form of bronchoscopy that, you know, you pass and you can have an idea of how the bronchioles look, whether they're clear or if there's a foreign body or if there's a malignancy that's occluding the bronchioles, preventing air from flowing through properly, right? That's the function of a fiber optic bronchoscopy. So you'd use that in the case of, for example, if you have a foreign body aspiration in a child, because them swallow some kind of toy, you can use a fiber optic bronchoscopy, right? But in this case, that's wrong. And what we can use to tell us that it's definitely wrong is just looking at this part where it says breath sounds. It says the breath sounds are shallow and symmetric. So if there was some form of foreign body blocking the bronchioles, blocking the airway, it would have said asymmetric. The breath sounds wouldn't pass through symmetrically, evenly on both sides. It would be asymmetric, right? If there was a malignancy blocking it, it would be asymmetric, but it's symmetric, so you can rule that out. So now we're left with B and E. Now let's go back to the patient. So yes, we know that, okay, they're 1 hour post-op. What do you usually give patients when they're 1 hour post-op and yeah, they're agitated, they're in a lot of pain? What would you be giving that kind of patient? Morphine, exactly. So this patient more than likely got morphine, some form of opioid, right? Now, the function of morphine, the function of opioids, if you give it in excess, is that it can suppress the respiratory system. So when it suppresses the respiratory system, the breath sounds can get very shallow, and it can be symmetric, but the breath sounds get very shallow because they're not making proper inspiratory effort, right? But in addition to opioids suppressing the respiratory system, opioids also decrease the respiratory rate. But this lady, she's breathing very fast. You get me? So you can't assume that, okay, yeah, they have an opioid overdose. If you have an opioid overdose, the respiratory rate would be low, and the breath sounds would be very shallow. So since the respiratory rate is high, we can rule out an opioid overdose, right? Option B says administer naloxone. So I know some of you guys were thinking along the lines of, okay, opioid overdose, give naloxone, because naloxone is, and I'm just going to put the arrow there because you guys need to know it. Naloxone is the antidote for opioid overdose, right? But in this case, it's not the answer. But it's very high yield that you know that naloxone antidote for opioid overdose. Also high yield that you know that in an opioid overdose, the respiratory system is suppressed and you get a shallow breath sound and you get low respiratory rate, and opioid overdose also causes respiratory acidosis. Follow me? But in this case, it's wrong. So based on elimination alone, we already have our answer, which is intubation. So now let me explain the exactly what's going on with this patient. Like what exactly is going wrong with the patient, right? So let's go through it. So as I said, it's a third order question, so it's a lot to unpack, right? So here we go. So yes, she had a surgery done, and she was extubated, but keep this in mind, and let me just box it. The BMI is very high. So when you have a high BMI, there are some things that you need to know for a high BMI, and it's going to help us, right? So there is a diagnosis called obesity hypoventilation syndrome or something along that line, right? So when you're excessively fat, you have a lot of mass on your chest. You have a lot of mass, so you can't properly inspire and expire, right? Because there's a lot of mass to lift off of the chest, all of that jazz. So what you find in obesity hypoventilatory syndrome is breath sounds are shallow. When breath sounds are shallow and the breathing overall is shallow, you're going to end up with carbon dioxide trapping, right? And that carbon dioxide trapping is what's leading to this respiratory acidosis that you see here, right? So I have that picture done right then and there, right? Now, yes, she was fat and yes, she did surgery, but because she did the surgery and she's a bit lethargic and she's tired and she's worn out, she doesn't have the energy to lift all of that mass off of the chest. So she starts breathing very shallow. And because she's breathing shallow, it worsens the carbon dioxide trapping. So you end up with respiratory acidosis, right? So that's what happened with this lady. Another key thing with obesity hypoventilatory syndrome is, in addition to it causing all of this problem during surgery, it still causes all of this that we mentioned over here in a healthy person that's extra fat. It still causes all of this data box here. And when it causes that, and you get carbon dioxide trapping, you get hypovolemia. I mean, not hypovolemia, you get hypoxemia, my bad. So I'm gonna go through that as well because that's important, right? When you have carbon dioxide trapping, you get hypoxemia. Now, what the lungs tends to do is you have blood vessels in the lung, and these blood vessels usually capture oxygen from the lung and send off the blood to the rest of the body to be oxygenated, right? But if the lungs itself is trapping a lot of oxygen, meaning you have hypoxemia, it's trapping all that oxygen, you're going to end up getting, and I'm explaining all of this because, guys, it's very important. You get vasoconstriction, right? It's a lot of pathophysiology, so I'm explaining. You get vasoconstriction in the lungs, right? So let me see if I can catch up a little drawing over here. One sec. Let me see if I can catch up a little. Oh my gosh, wait. All right, good. Let me see if I can catch up a little drawing here. This is the heart, right? Poorly drawn heart. And these are blood vessels, right? And over here, boy, I'm not even overdraw the lung, but yo, just pretend this is the lung. Yeah? This is one lung. Anyways, what blood vessel go into the lung? But look how the blood vessel is very thick. I mean, wide, right? In diameter. So blood can easily pass from the right side of the heart to the lung with ease. It's not straining the heart at all, right? And you have more blood vessels in the lung here. Anywho, when you have this hypoxemia, what's going to happen is, put in an arrow, right? When you have hypoxemia, which is this thing we're talking about, you get vasoconstriction. So this is the heart again. But now this is the blood vessel that's going to the lung, and the blood vessel that's in the lung. It's a bit more tight. So what you think is happening to the right side of the heart? What does the right side of the heart have to do in a situation like this? Does it have to work harder? Does it work less hard? What do you guys think? I'm just making sure. Yeah. All right, good. So it has to work harder. It start work harder, and it's like, boy, it's a push. It's a contract hard. Over time, what you end up with is right ventricular hypertrophy, right? So it can lead to right ventricular hypertrophy, and then over time, the right ventricular hypertrophy can eventually cause left-sided heart failure as well. And then you end up with heart failure because of obesity hypoventilatory syndrome, right? So it's a very important pathophysiology that you have to bear in mind because they test it a couple of times, but probably you guys go through the past papers, but you don't realize. But yeah. So we can move on. I'm skipping this. No, I'm clearing it. So I'm giving you guys a little time for kind of snap a pic if you want. Counting to 3. 1, 2, 3. All right.